media in the
Yes.
future. Now it's 4 o'clock. Let's see how people are going to start joining the meeting. So that's Sue, one of my clients, is here.
Mm-hmm.
Hello, Sue.
Hello, Leona.
How are you doing today?
I'm great, thank you. I haven't put my headphones in yet. I've just come back from church. Very good to see everybody here.
Nice to see you too.
I'll put my headphones in. Right.
Sure. We're going to be waiting a few minutes to see who's going to join the meeting.
That's great. Yes. Well, these things are, you know, a bit, they're always a bit hit and miss with time zones and, you know, other commitments for people. I'm lucky at the moment. I don't have too many, but the church is obviously a mainstay, and I've just come back from there and they're very supportive. So that's, you know.
That's good. Yeah.
You look very smart, Leona.
Thank you. Thank you, Sue.
And I like the background. Prince Solomon designed it for you, didn't he?
Yeah, he is.
Yeah, I saw that on your feed. But yeah, I mean, and it's very nice to meet Alaa El-Hussuna.
Yeah, Dr. Alaa El-Hussuna. Yeah.
Alaa El-Hussuna.
Right, right. So if you want to ask any questions for the moment until everyone joins.
Well, I think my main question is it possible to go into remission? Because I'm finding I can tolerate a bit of gluten, can't I, Leona? It's not like, you know, so I mean, so long as I'm careful about my soy and I eat small portions and I eat healthily like you told me to do. And I take my medication because, of course, I'm taking the pentasamycin, so I'm on an anti-inflammatory medication, and I had my diagnosis when I was 38 and I'm 54 now. So I guess you're going to say to me that I don't know if I'm okay. I mean, I've still got to have my colonoscopy to make sure everything is as it appears to be, but I don't know. What do you think, Leona?
Well, like you said, you're not strictly sensitive to gluten. So sometimes you have gluten and it's okay. Sue, Dr. Alaa was suffering from a lot of bloating, flatulence, and right, gases.
And I have, yeah, and in the past I have had blood in my motions, and I've had colonoscopies, and they diagnosed ulcerative colitis, so they put me on the pentasamycin. But I had my diagnosis when I was 38 years old, and I'm 53. I'm 54 on May 1st now. So, but yeah, I mean, I was having a lot of issues when I came here, but my diet was very poor indeed, and Leona has improved at no end with her dietary advice, and she's put me onto all the appropriate websites where I can get the right recipes and what I should be eating. And indeed, this morning, when she was WhatsApping me, I was eating porridge with natural yogurt and fresh blueberries, which, you know, is nice. And because it was like a sachet, it made sure it controlled my portion size. It was a nice small portion rather than a massive bowl. So, you know, I think Leona's been amazing. Yeah. Yeah, absolutely amazing.
Thank you. Do you have specific questions for Dr. Alaa regarding any of the symptoms, the treatment?
Well, I think if you haven't got any blood, is it fair to say you're not in too much trouble, or you don't know? You've still got to have a look at what's going on in there just to be sure.
Well, blood in this tool is just one of the symptoms. So maybe you don't have blood, but you have other symptoms. So symptomatic free, what we call it, symptomatic free. If you are free from symptoms, so you are in remission.
But if I was getting the bloating and the diarrhea and the flatulence, then probably not. But I mean, even though but I mean, Leona has already advised me anyway. I mean, although it would seem I am in remission, because in England for some reason they've only been giving me colonoscopies every 5 years, and I think I missed last year because of unforeseen circumstances. So hopefully I'll be having a colonoscopy this year in the next couple of months, just as a checkup.
Yes, good idea to have the colonoscopy to check up, because if you have still the symptoms despite the dietary modifications, so a checkup in the hospital needs to be done. Maybe there is a willingness to modify the treatment so that it can give you better freedom from symptoms.
Yeah. Well, I think that, or if anything, the opposite, because I think I've adhered to so little of the diet Leona has given me, primarily changing to soy drink rather than normal milk, and cutting down my portion sizes and eating fresh, healthy food. Potentially even maybe reducing down the pentasa if there aren't any other symptoms in there, because obviously, I mean, I've been on that pentasemsalazine now since I was about 38 years old. So, you know, I mean, all these drugs, they can have long-term effects, I presume, if you're on them forever.
Yes, of course. The less drugs, the better. So we always tell our junior doctors that drugs are useful poisons. So they are just poison, but they are useful poison. So we use them
Selective,
with
right?
caution. Yes. So we use them with caution, and only if needed. If we can avoid them by using diet or any other things, so it is even better.
Yeah, I think that's a very good point. That's well, and I think it's and I think the one that I'm on is a what do they call it? An immune suppressant. So I don't know, but it's not actually a steroid. I don't think. Is pentasemsalazine a steroid?
No.
Right. Well, that's one thing, because steroids can be dangerous in the longer term, can't they?
Yes, exactly. They have many side effects. They are effective and they can induce rapid remission, but on the long run, if the patients use them for chronically, so they have many bad effects, side effects.
I experienced that, from using prednisone for a long time. They were not giving
Okay.
me biological treatment. And
Yes.
then they suggested that I stay on a maintenance dosage of prednisone, which was not truly a wise decision, but because they couldn't offer anything else. And it caused a lot of side effects, not to talk about the mental effect it has over me, on a long term. Have eye problems, osteoporosis, mental confusion, a lot of side effects that I decided to stop it, even it's the lowest dosage that I could use, which is 2.5 milligrams or 5 milligrams. It has a potential to damage a lot of body parts on the long term.
Yeah, I've heard of prednisol. They've never put me on that. Luckily, I've only ever been on the Pentasa, and yeah, I think at one point I was getting blood, so they said I could increase the dosage to two tablets in the morning and 2 tablets in the evening, rather than what I'm on now, the maintenance dosage of 1 in the morning and 1 in the evening. And I think they may have run a colonoscopy round about that time, but no. I mean, I think the holistic approach that Leona takes is very valuable, because I think diet plays a lot, as well, not for everybody, but for me, I think diet has played a large part in helping to get me better. Even if I have to remain on the Pentasa, but I think where before I met Leona, I didn't really want the colonoscopy because of various reasons, like I struggle with fasting, and there's all the issues. You've got to get to the hospital and you've got to have, the sedative. And I've got hemorrhoids down there as well. Things aren't too good down there, so I'm a bit worried about having something put up my my anus. But I do think now that it's necessary, but I don't know whether they're going to give it to me. The review will have been done into my referral to the QE gastroenterology department by the middle of March. So but if I'm asked for my opinion again and they call me in, which I presume they'll have to, I will say that if they don't mind, I do think a colonoscopy would be a good idea.
Sue is in UK, Dr. Ala.
Okay. Yeah.
And
Where?
that is in Denmark.
Oh, Birmingham. I know many people,
Yeah.
many IBD working Birmingham. Queen Elizabeth Hospital.
I'm about 10 minutes by Uber away from the QE. It's the most amazing hospital. My mum was in there
Yeah.
10 years ago.
Who's your doctor?
I haven't got one at the moment. All I've got at the moment is a referral to the gastroenterology department. I think
Okay.
there have been issues because I've had issues in the house I'm living in. It's temporary accommodation and it's a house share.
Yes.
So,
But that's good. It's a good hospital,
oh
and
yeah,
they are really
yes,
competent, and they are very good, and they are doing good research, good
yeah,
clinicians. I have visited the hospital.
yeah.
It's really amazing.
Yeah, I have every faith in them. It was not them that I doubted. It was me from this perspective of would I be able to starve myself effectively? Because on one occasion I was
Yeah.
called for this colonoscopy in Kidderminster, and it was complicated. My brother was supposed to be taking me and he didn't want to take me, and he was downstairs having a row with my mum, and I was upstairs trying to fast and flush my system out, and then I got a migraine, so of course I didn't finish the flushing out. And when I showed up the next morning, they said, well, we're sorry, we can't do it because you're not ready for us. And so it was all a bit of a disaster. And at a place like the QE, I wouldn't want to mess them around like that. And now I'm on my own, but then that brings other issues because I've got to cope with fasting and getting myself there on my own in Uber and get myself back. But having said that, I'm very close to Christchurch, an evangelical church over the road. So provided I remain here, I have been indicated that somebody there would be prepared to support me, someone who's had colonoscopies herself, so she knows what it's like.
Okay. Are you a member of the Crohn colitis organization?
No, I looked at the American version and I gave them a donation to say thank you. But no, that's a good idea. I wasn't even aware. I think my consultant many decades ago when I was 38 shoved a load of paperwork at me about Crohn's and colitis, and I didn't do my
Well, Crohn
homework.
colitis organization in UK is also an active organization.
Yeah, I told
And
Sue
yeah,
about
so
that.
Yeah,
it's a good idea
yeah,
just to contact them, listen to and there are some activities and you can
yes,
participate, and you can have also some support groups because they have some support groups to
yeah.
things like this when you are going to coloscopy or something.
Well, that's well worth knowing then, yes. And I don't know why I don't have I don't know why I don't have
You can look them up online, Sue. Just write
yes,
down Crohn's
yeah,
colitis UK, and you'll
yeah.
see the organization there.
Well,
Yeah.
thank you for focusing me, because unfortunately what's happened, you see, Dr. Alaa, is that Leona's been trying to work with me intensively and things have been going well with the diet, but because I've had issues in this house, specifically with one of the other inhabitants, it's rather waylaid me emotionally, and we have spent quite a lot of time talking. But I class her as a holistic IBD coach, so not just dealing with my diet and my ulcerative colitis issues, but also with with everything else. But I hadn't thought, to be quite honest, because I was thinking, well, if I haven't got a kitchen and I can't get myself organized, no point looking at these websites because it'll all be recipes. But you've pointed out something that's patently obvious, which is that it's not just about food, it's about
No,
support groups and additional information.
yeah, even talking and talking with people who suffering the same symptoms like you,
Yeah,
it
yeah,
will give also some support because
yeah.
psychology is very important.
Yes, it is.
It
It
is
is.
really neglected, but it is very important.
Yes, you're right. Leona, can I say before we go any further with me, when I tried to log on to this meeting, because there's only me here, it wasn't bringing up the event on the LinkedIn page. I don't know how you've been inviting people. I don't want to monopolize the conversation while other people
Well,
are trying to get in.
How did you get in then?
I think I went on. Hold on, let me have a look. I went on the. I think I went on it had put it in my calendar when I first went in, but let me have a look and I'll just go back.
Yeah, it's good. You want to make sure, we want to make sure that everyone could
Okay, let's have a
join
look.
the meeting.
Okay, yeah. Let's go back. If I share my screen with you, can you see now how my LinkedIn looks?
No, it's not sharing.
Okay. Well, maybe it doesn't matter, but you need to know, because if people can't get in, that's more
Yeah.
important than talking about me and my.
Yeah, I'm wondering, how did you get into the meeting? Didn't you use that same link that I have on in the
Well,
event?
I can't find anything on LinkedIn. I can only find the I can only find now the share button on it. But you have a look on your LinkedIn. That's the answer, Leona. If you can, if it's possible to open two screens. And I guess, but I guess you can't.
Yeah, I'm opening the LinkedIn screen. All that people have to do is just click on that, you know, on the event link. That's all
Oh,
that they
okay.
have
Well,
to
so
do.
long as it's showing on yours, it must
Yeah,
just
let
be
me
at
see
my
here.
end.
Let me
Yeah.
just make sure that it's completely
Yeah.
showing
If
there.
you just make sure, because you've
Yeah.
been ever so kind to me, but it's only 2:17, and
Yeah, people who want to join would have joined by now. I see what you mean.
but it's just strange because it didn't come up as a LinkedIn audio room unless you were specifically running it
Yeah,
through.
it won't come as a LinkedIn, no. All that you have to do is just click on the link, the Google link, and it brings you to this meeting. So it's not a
Well,
LinkedIn event, yeah.
well, let me have a look and go back and see how I got in. I think I went
You
to
clicked on,
event link.
let me share the
I'm
screen
with
with
you.
you
Yeah,
here.
you're quite right, Leona. Event
Mm,
link is what I needed. I was
mm,
looking for the word
mm.
join, because normally when I
Yeah.
join audio rooms,
No,
I
join
get
for the audio, not for this event. This is like
okay.
a third party,
Oh,
connection.
okay.
Yeah. So
Yeah. Well,
you
that's
clicked on the link for Google Meet
good.
and it brought you to the meeting, which is very good that you're here. So let's not, let's use the opportunity,
Yes,
Dr.
to
Ala,
talk to
for
Dr.
everyone
Alaa.
who is not here, who has not joined the meeting. Let's start by you introducing yourself and then go along with the
Yeah,
meeting agenda that we have prepared for the meeting, and it
great.
could be recorded and we could post it later on for those who could not
Great.
attend.
Marvelous. Okay, I'll get my notepad
Yeah,
out,
sure.
Leona.
Okay.
So I'm a colorectal surgeon based in the north of Denmark, and my focus in the last 10, 15 years was inflammatory bowel disease, and specifically also how to make the treatment available and the management easy for those patients who are suffering from inflammatory bowel disease. I'm really looking forward to this talk that Dr. Leona has arranged, because we would like to interact with our patients and everybody who's taking care of patients with inflammatory bowel disease, answering their questions and helping them.
Great. Thank you, Dr. Ala. So let's start by differentiating the two types of IBD, or maybe there's more than two types, but the most common ones are the ulcerative colitis and Crohn's diseases.
Well, as you said, there might be many types, and the division or the classification to ulcerative colitis and Crohn's disease is being challenged now with genetic studies showing that the Crohn in the colon is more similar to ulcerative colitis and can be same as the ulcerative colitis. But anyhow, let us follow what we have in our hands now. So Crohn's disease, ulcerative colitis, and indeterminate colitis. But there are other also types of colitis like collagen colitis and other types. But the most common are these two.
Okay,
And the difference between the two is genetic. the immunological profile is different between these two. The parts that affected from the gastrointestinal tract are different. In Crohn's disease, any part between the mouth and the anus can be affected. In ulcerative colitis, it is mostly the colon is affected. So this is one of the main difference. The morphological changes occurring in the gastrointestinal tract can be different in Crohn and ulcerative colitis, and that's why we do the coloscopy, because this colonoscopy can help us to identify the morphological changes in the small and large bowel, and then we can pose the diagnosis Crohn or ulcerative colitis. However, sometimes it is not like as easy as this, and there are many of the conditions are in the gray zone, and usually the examining doctor take biopsies from the affected areas, and they are analyzed to see if there are these changes are similar to Crohn or similar to ulcerative colitis.
We will get to that, Dr. Alaa, once we talk about diagnosis. So let's talk a little bit about the common symptoms for these two diseases.
Most of the symptoms, they are concentrated on diarrhea, bloody diarrhea, malnutrition in the form that weight loss because of the malabsorption. This means that the patients will eat, but the absorption is bad, and that's why they lose weight, because they don't get the nutrition needed by their body. Sometimes there are extra intestinal manifestations affecting the eyes or joints or even other organs. Skin, for example. The most important thing is that we need to say that the inflammatory bowel disease is a disease of immune system. What does this mean? It means that it is a systematic disease affecting all the body, because the immune system is there, all the body. Although we can identify specific areas where the disease is attacking or usually is affecting them, but it is a systematic disease. This is one point. The other point, inflammatory bowel disease, they have the pattern of autoimmune disease, and this pattern is remission and relapse. So even if the patient don't get the treatment, some of them, they will get to remission phase, but this remission phase is not always known how long it will be. Sometimes it is few months, sometimes a few years, sometimes it is long remission phase. So these are mainly the general symptoms of those two diseases.
Thank you, Dr. Alaa. How about talking now about the diagnosis of each of them, Crohn's and ulcerative colitis?
Yeah. The cornerstone in the diagnosis is the endoscopy. Usually the endoscopy is colonoscopy, and in some cases, in rare cases, we need to do a small bowel endoscopy, but mostly it is colonoscopy that it is diagnostic. Another option is the capsule endoscopy. And in capsule endoscopy, it's a small camera that the patient will swallow, and it will go through the gastrointestinal tract taking photos, and then these photos are analyzed. There is a huge advances now in using artificial intelligence to analyze these images, because there are hundreds of images. Usually there's someone is trying to scroll down those images and see them, but with using algorithms, artificial intelligence algorithm, this is promising technology to make this easy, and thus the patient, they don't need to go through the colonoscopy. However, I would use this opportunity to tell the patients and the caretaker of the patients that colonoscopy is not a dangerous procedure. And colonoscopy in the hands of trained physician or surgeon is a simple procedure, and usually it doesn't take long time, and usually it is not painful. Some discomfort, it can happen, but it's not supposed to be a painful procedure. the colonoscopy itself has been changed and developed and evolved. So the new endoscopes that we have, they are really very flexible, and the investigation is becoming easy. So if you have the chance to have the colonoscopy, don't say no to it, because it is a good procedure.
Yeah, that's
Great.
great. I will I will ask the question absolutely now and say that, you know, I haven't had a colonoscopy or for 6 years, and if they're going to keep giving me this medication, they've got to know what's going on in there, don't they? And also, in any case, I'm with Leona now. I'm one of her patients, so I mean, her opinion is I should have the colonoscopy, so she has to have her say as well. And really, I suppose they ought to send her a copy of, you know, of what of whatever the outcome is, whatever they find. Because I'll tell you what else was also negligent was last time I did have a colonoscopy. I think he didn't keep a video. It was done by somebody from another country who was a locum, who didn't provide photographic evidence. He just drew a diagram or something. You know, it wasn't satisfactory at all. And they did offer me the chance to have it redone, but I'd found it so traumatic having that one done. I said no, no, thank you. And I think that was the right decision at the time, because I was still living with my two brothers. And but I think now I'm with the QE and I've got Dr. Leona on side, and it's been 6 years. I think it's time, and hopefully it will be good news. But in the meantime, I need to continue, continue working on my diet, because, you know, now the flatulence and diarrhea does seem to have gone. But having said that, it doesn't take a lot to get it back on board if my diet slips, you know.
Yeah, so we will get to all of these tips that,
Yeah.
talking about the diet and the holistic approach later on during the
Yes.
session.
Thank you, Leona.
I'm gonna have Dr. Alaa tell us a little bit, are there specific diagnostic tools for Crohn's and others for ulcerative colitis, or is it the same techniques used to diagnose both? You've said before about taking biopsies that could differentiate between the two diseases. So
yeah, there are so many groups working, trying to find some biomarkers for inflammatory bowel disease. At the time being, we have the colonoscopy, the biopsy, we have the calprotectin, which is usually measured in this tool, and it gives us an idea about the disease. So these are the diagnostic tools that we have in our hands now, but there are a lot of work to get some biomarkers using the blood, for example, blood investigation. I know there are few groups working on impedance, which is kind of making a kind of electrical analysis of the blood samples to see the proteins and the changes in the proteins. This is a field in itself, the field of biomarkers in IBD and the diagnosis in the IBD. But generally speaking, these are the main tools that we have in our hands now.
I've seen lately, some with the Crohn's Colitis Foundation of the United States, a machine that detects biomarkers from the sweat of a person. Have you heard about such a technology, or is it something?
I've heard about this technology in Parkinson, and there might be also some other groups trying to investigate this for other diseases. So it is a possibility, because all the body fluids are affected by the inflammatory bowel disease. As I said, it is a kind of systematic disease, and therefore some people who have inflammatory bowel disease, they have other autoimmune diseases. You can see patients with Crohn and having rheumatoid arthritis, or patients with ulcerative colitis having, for example, psoriasis or other autoimmune diseases.
Yeah.
So all those diseases, they are under this umbrella, autoimmune diseases. This means that we have a good chance to identify the changes in the immune system and try to figure out which one is the Crohn and which one is the ulcerative colitis and which one is not affected by the other autoimmune disease.
Great.
I have ulcerative colitis actually, and I have a vitamin D deficiency they'd established on my last blood test, and they also I also have a fungal nail infection. They've put me on terbinafine for that, so I'm taking that. They're running a blood test in a couple of weeks' time, I think. So yeah, I discussed that as well with Dr. Leona. There's various, other things going on because of the autoimmune deficiency, in my system.
Yeah, that autoimmune deficiency can affect other parts of the body other than the colon, as Dr. Alaa is trying to say.
Yeah.
Okay, so in terms of treatment options, Dr. Alaa, what are the most common treatment options for both diseases and availability, accessibility?
So after having the diagnosis confirmed, so there are different treatment options to start. I will talk about the treatment options generally, very generally, because the details can be found elsewhere. So generally speaking, steroids are the first drug to be used in Crohn's disease. 5-ASA, it's a drug also is being used in ulcerative colitis. Also, Pentasa is also another drug to start in ulcerative colitis. Then there are two approaches for the treatment. The first approach, starting with these medications, they are systematic medications. Of course, Pentasa works locally also, but steroid is systematic. And when the patient is not responding, so there is another step going to the immunosuppression, like azathioprine or other drugs. And when this is not giving a response, then going to the biological treatments. And there are many biological drugs that has been developed with different criteria and different mechanism of actions. There is another approach to the treatment is to identify the patient who has severe disease and then starting from the most potent drugs, giving them the biologics, and then go down and give them maybe immune suppression, and then maybe give them steroid and then stop the medications. This we call it the top-down approach, and the other is the scaling approach or bottom-up approach. Well, when the patient is not responding to treatment and the patient has symptoms, then surgery should be considered. And surgery should be considered early. The problem is that many patients are afraid of surgery and they think that this is crippling and they will get stoma and they will get many complications and all these things. And they try to stick to medications as long as they can. This is wrong. Surgery has developed. Now we are using the minimal invasive surgery. We are using the laparoscopic surgery. So 3-4 small holes, 5 millimeter, and then there's a camera and the instrument, and then we can make the surgery. The longer the patient waits, the more difficult will be the surgery, and the higher the risk for getting a stoma, because then the bowel will be destroyed and it cannot heal, and that's why we give a stoma, because we cannot make a kind of suturing the two bowel segments because the bowel has been destroyed or it's very weak, the bowel wall. So the longer the waiting time, the more difficult the surgery. So if the patient gets the offer of surgery, so they should consider this offer as soon as possible.
Great. So what are some of the, maybe you're saying that patients are afraid to do these kind of surgeries. Are there side effects to the surgical intervention? Doing an ostomy, having to live with a bag, are they reversible or are they permanent?
Well, there is no surgery without risk. So even if you do any surgery that we consider is maybe a simple procedure, but it has the risk. and even simple procedure. We have an example of hernia operation was done by expert teams, the king, Morocco king, many years ago, and he died after the procedure. So it's just an example that any procedure, even if done by the best hands, has a kind of risk for complications. So what type of complication can occur? It can be if we are making anastomosis, that's to say 2 bowel segments. They can be a leak in this anastomosis. They can be infection, because as we said, the inflammatory bowel disease is a disease which is systematic disease affecting the healing power of the patients. So wound infection is also another complication. Other complication is infection in the lungs or infections elsewhere in the body. The risk to having stoma is when there is no possibility to make the anastomosis. And this, as I said, because of the bowel destroyed, because the disease is very aggressive. And that's why we think that it is a good idea to have the surgeon in the IBD management team, so that the possibility of surgery can be discussed at early stages when the patient is not responding, and not waiting until the patient is crippled by the disease. So to answer your question about if it is permanent or it is temporary, most of the time they are temporary stomas that we do for those patients who are young and can tolerate to have anastomosis.
Does that affect their quality of life? Living on a daily basis with a bag attached to her coat?
Yeah, it does. It does. It is not, and in many countries, it is. There is a stigmata that the stomy is very bad, and the patient will try everything to avoid the stoma. But as I said, it is not something that we do always. It's not. It doesn't mean that every time there is an operation, so there is a stoma configuration. It is only when there is no possibility to make the anastomosis. And again, I would say the cause that we cannot make anastomosis because the disease is aggressive or the waiting time has been very long. So avoiding this, of course, for the Crohn's disease, also avoiding the smoking, because it's also affect the integrity of such anastomosis. So
yeah,
the
but I
patient,
heard that with ulcerative colitis, it's okay, it's better to smoke, but with Crohn's, you're not supposed to be smoking.
yeah, with Crohn's, yes, right, that it is it's affecting in Crohn's disease. It is giving more aggressive disease if you smoke. In ulcerative colitis, it might not have the same effect as Crohn's disease. But doesn't mean that it is a good idea to smoke, because smoking affecting also the healing power. So even if it has some other effects, which is not like the Crohn, it continue to affect the healing power and other systems in the body. So smoking is not good for the IBD patients.
I agree. Now, in terms of treatment options, let's talk about availability and accessibility to these treatment options. Are these medications available, and the surgical option, is it available to majority of people who are living with IBD, or are there certain restrictions from getting access to these, especially the strong biological treatments?
Well, it depends where are you living in the world, unfortunately. So in some countries it is available and is supported by the tax payments. In other countries it is in private sector, like in USA, for example, and in some countries it is not available. The medication is not available and the care for the IBD is not available. In some countries, it's not available at all, not for IBD only, but also for other conditions. So it depends where are you in the world. But in this regard, I would recommend the patients to gather together in some kind of patients association and try to increase awareness and then try to lobby for better treatment of IBD patients, because this is the only way forward. You know, now in Europe, there is so much focus on cancer and the patients cancer organization. They are very strong and they are lobbying for their patients. So we can do this also for inflammatory bowel disease. Maybe we can join forces, or patient can join forces with the autoimmune disease and have it in one organization, the organization for autoimmune disease patients, because then you have all the patients with type 1 diabetes, with rheumatoid arthritis, with psoriasis. So it will be a good organization, big and strong, and can lobby to have the treatment and access to treatment.
Exactly. You know, you've talked about cancer, and we know that people who are living with IBD have a high risk of developing cancer on the long term, colon cancer, you know, liver cancer, the different types of cancers. As you mentioned, you know, having to work with these associations as an initial step can prevent, you know, the development of cancer on the long term. Thank you, Dr. Alaa, for that. So we'll get to all of your questions after we finish this discussion. We'll allow some time for all of the questions that you have at the end of the session. So, Dr. Alaa, I know from experience, I've been living with Crohn's for over 15 years, and I've, you know, had a difficult journey with a lot of adversity and challenges. It wasn't an easy one. So I learned that medication by itself cannot keep a person or a patient in remission. Medication is very necessary to put a patient into remission. But to stay and, you know, keep the remission, there are other aspects of life that need to be considered. And that's where I came up with the, you know, idea of the program of the holistic IBD support for patients who are living with Crohn's or ulcerative colitis, knowing that it can touch every single aspect of life, you know. So can you tell us more about, other than the physical stress that, you know, the disease can put on a patient, what are the other, you know, mental, emotional, social, you know, difficulties that a patient can face and get challenged with to maintain balance?
Yes. So we know that stress is one of the major causes of diseases. It affects the immune system and it can trigger many diseases. One of them is the inflammatory bowel disease. We don't know how this is exactly is happening, but there are many studies trying to identify how stress affecting the cells in the mucosa of the bowel and starting a reaction that trigger immune reaction and then triggering the disease. General advice to avoid stress, and it is especially for the patients who have autoimmune disease and inflammatory bowel disease, because you know the saying that my stomach say that this is not correct, because you feel that something is happening. There is something which we call it the brain bowel axis, or this brain gastrointestinal axis is real, and it is identified, and there is a strong evidence that our psychology affecting our bowel. So avoiding stress, and in those who are having a stress, they need to have consultation with some people who can help, whether professional or people having the same disease. It helps, but they shouldn't neglect this, because it is important and is part of the treatment.
I totally agree with you regarding the stress management. Stress can cause flare-up at some point, and
Exactly.
you go into a vicious cycle of getting the physical symptoms and then getting again stressed about that, about having the continuous diarrhea and bowel movements and the other, symptoms. So it's like a vicious cycle where your physical health can affect your physical health, and psychological health can affect your other
Yes.
health, like the mental and the emotional health. What about lifestyle and changing habits? Are there, certain guidelines for a certain lifestyle that will put a patient into remission or keep them in remission?
Yes, we already talked about smoking, which we agree that it is not good. It's not a good idea. Alcohol consumption, it's also it's something that can be modified. The exercise, because we are living in sedentary environment. We are sitting in front of our computers for hours and we don't move a lot. So this affects also all our body, because if we move, the bowel also is moving, not literally, but the bowel, that's why when we go to sleep, so the bowel would get the signals that we are sleeping, so nothing, that the movement will be kept to minimum.
Rest
When we
and
wake up,
digest, right?
yeah, when wake up, then there is the movement start in the bowel, and that's why many people will go to the toilet in the morning, because now they are wake up and there is a movement. So motion and exercise, very, very important. Fast food is fast killing, so don't kill yourself with this food. Um, Food with conservatives, like canned food and other types of food which with chemicals, they are really very bad for the bowel. Also for the healthy people, not only for the people with IBD. Don't give it to your children. Don't eat it. These are full with chemicals, and we don't know exactly what is happening when we eat them, because it's difficult to get some studies about this. But we know definitely that many of those chemicals, they can trigger disease. They can trigger inflammatory bowel disease. They can trigger cancerous genes. These chemicals are not made for human. And maybe some people will argue, yeah, but many people, they are taking them without how nothing happening to them. You cannot say this, because you are not following them all the rest of their lives. You just seen
Long
them
term,
once. So
long
even if they
term.
have been eating the chips, for example, for 50 years, how do you know that the next 50 years will be free? So avoid these food and eat naturally. Try to make exercise and avoid stress. This is the general.
How about sleeping habits?
Very important, because sleeping, there are many studies uh, uh, showing that sleeping and sleeping patterns affect the microbiota. The microbiota is a kind of bacteria that we have it in our body, and most of the bacteria is in our gut. This bacteria is very important for the digestion. It's very important for hormonal balance in the body. This bacteria is affected by changing lifestyle, like sleep, also sleep times. For example, some people, I have seen some people sleeping in the day, and they are awake in the night, and this is really very bad for the body, because the body is built, and the hormone are built to us for to work in the day and sleep in the night. So bad sleep in the night will affect the microbiota, like useful bacteria, and it will affect the gut also.
Great. That's very valuable information. Now, talking about sleeping habits, we talked about how many hours you think there should be, how many hours of sleep a person with IBD or generally have to sleep in order to rest.
Different, because everybody, they have their own rhythm about how much sleep they need. I have seen people who say that they are satisfied with 4 hours. Generally speaking, most of the people, they sleep 7 to 8 hours. Some might need more, especially for the inflammatory bowel disease patients with IBD. They have IBD fatigue. And this fatigue is really difficult to describe. It is not like the fatigue that you get after a long exercise, because fatigue
Definitely.
after long exercise, if you get kind of rest few hours, then it will disappear. But this IBD fatigue, it's in the bones, it's in the whole body. Even if you get many
That's
hours, it
because of the
doesn't.
malnutrition, maybe, Dr. Ala, because of the
One of the
malnutrition,
causes, nutrition, and the nature of the
deficient of
disease.
vitamins and
Yeah,
minerals.
so the
Yeah.
nature of the disease also affecting this. So the time to sleep is or the how many hours different people.
Okay. Now, regarding managing stress, what relaxation techniques you would suggest for patients who live with IBD, on the long term? Do you have specific relaxation
Well,
techniques?
I'm not the expert in relaxation, so there are many people or specialists, psychologists, and those who are trained to make the relaxation exercises. They can be consulted. Of course, what I can advise is that if you have stressful life, then you need to have a break from your stress, because otherwise it will affect the disease, lead to flare up, and maybe it will be difficult to manage it.
Excellent. Now, regarding diet, are there specific food that you would recommend for those who are living with IBD? You would suggest that they increase the intake of certain food. Now, we know they have to keep themselves hydrated, drinking plenty of fluids and 2 liters of water. What about certain specific food that can work with the immunity, boosting immunity and, enhancing the coping?
Well, again, it's an area in itself in management of IBD, and that's why in the good centers, IBD centers, where they have dietitians always as part of the IBD team. This is not always there, even in Denmark. In many hospitals, they don't have the dietitian, the IBD team. But we in the ECHO, we are in the European Crohn Colitis Organization. We published a paper about the roadmap for optimizing patients with inflammatory bowel disease. And in this paper, we wrote about nutrition, and we stated that it is very important to have dietitians there. So I cannot recommend just something which is general, that one size fits all. I don't think that there is something one food fits all. I think I will leave
Keeping a
this for the
journal, I think.
dietitians. Yeah.
Keeping a journal for each patient, specific
Yes,
food, and
exactly. Each
a
patient
journal
what
of
they react,
Mhm.
and the dietitians, they have different menus, and they go, yeah, like the treatment. So when we give the treatment which is not effective, we change to another treatment. They
Right.
have different menus. They can change it.
Therapeutic diets. That's what
They,
they call them, right?
something like this,
Therapeutic.
managing through diets. Yeah.
Okay. Are there specific tips you want to give to patients who don't want to just live with IBD? They want to thrive and reach their full potential, living with this chronic, untreatable disease or incurable disease.
Yes, it is uncurable now, but maybe it will be curable in the future. I hope in the near future. What I want to tell those patients, that um, taking life as it is and be living it happily, it will have a good effect on their disease. This is one thing. The other thing is that it's very important to have IBD specialist, and not, because in some countries patients they go from one doctor to another doctor. This is very bad for such a disease, because you need somebody who knows the disease very well, and somebody who can also follow up what
Mm.
is happening in the for the patient, because things will change from day to day, and you need somebody who has been there, and don't tell the story from the beginning, because then they will start the investigation from the beginning and the management from the beginning. So two advices: live your life as you can, and have a specialist to support you, or kind of specialist center there where there is knowledge about IBD.
Great. Thank you so much for your advice, and thank you so much for this valuable information that you have, given us during this session.
Thank you
Um,
for arranging this meeting.
Sure. We're going to allow Sue to ask some questions, but before that, I want to say that people who are interested in joining my program, which is the Holistic IBD Support Program, to balance the physical, mental, social, emotional health, they can visit my website. They can book for a 30-minute discovery call or 1-hour session, and then they can join my LinkedIn group. I have also 2 newsletters to subscribe to, one through LinkedIn, another one through Substack. And it's there for support, educating, raising awareness, and advocating definitely for patients who are living with IBD. Now, Sue, you have specific questions for the last 5 minutes to Dr. Alaa.
Well, I think most of them have been answered, and you've both been amazing, and I will absolutely be pushing for that endoscopy, that colonoscopy at the earliest opportunity. And and to keep my hands on a gastroenterology consultant at the QE on an ongoing basis. And just to mention as well, one of the questions I was going to ask is, can it lead to bowel cancer? Because funnily enough, my dad did actually have bowel cancer, and they fitted a partial ileostomy on him, which they were going to reverse at a later stage. Unfortunately, he was nearly 80 and he was in such poor health. He actually had a heart attack suddenly after the operation. So we lost him suddenly, and that I was 40 then, and I'm 54 now. So I don't want to go the same way, and certainly I'm if there are any problems, I want them nipped in the bud. So if I have to have an ileostomy, it can be done, as you were saying, before things get so bad. It either can't be done, or it's altogether more serious than, but also to say that the lifestyle changes that Leona has recommended already to my diet have worked miracles. So hopefully, that won't be the case, but we won't know until they do it. And also, of course, I do have the Calm app, which I got not because Leona told me to get, but because Google recommended it. And I have been doing mindful movement and meditation and mindfulness, and I have found that very helpful. But I do enjoy normal physical exercise, so I'd like to branch off into swimming at a later stage. But and my only final question is Dr. Alaa on LinkedIn?
Yes, he is.
Okay, so I can follow him, I suppose, on LinkedIn to see.
You are welcome. You are welcome. Everybody is welcome, and
Great.
we'll be happy to arrange such an event again with Dr. Leona to answer the questions.
Wonderful. Yes. Well, it's just a shame I was the only person who showed up, but it's their loss.
Don't worry. We say that we work our best. It is the intention that we will be judged by, not the success.
Well, anyway, you've got this recorded now, Leona, so it'll be useful for you to have as a marker in the sand.
Definitely.
For
yeah, definitely. Yeah, for those who want to benefit from the session. And as you see, you were sitting there and taking notes. So if you didn't find value in that, you would have not.
Yes, no. And I will. And of course, the other valuable advice is to go to the Crohn's and Colitis UK website, so that
good idea.
So when it comes time for me to have this colonoscopy, hopefully I'll be part of a group of people who've been through it, and they can provide me with the emotional support.
And you can also provide others with the knowledge that you have. There is nothing better than helping other people.
Yeah,
this is the best thing.
And indeed, I can recommend them to. I can recommend them to Dr. Leona, because she's there as well. So yeah.
Thank you.
Very good.
Well, I'm doing my best to help people as much as I could with the experience that I have with Crohn's.
Yeah.
Very good, Leona. Thank you very much, and thank you for this opportunity.
Thank you. Sure.
Hopefully,
looking forward for future collaboration.
Thank you. Bye bye.
The gratitude's all mine. Thank you. Bye bye.
Thank you, so. Thank you, Kiona. Bye bye.
Bye bye.